So now we're going to move into talking about the continuum of care for our loved ones. And the first thing that I have for you is to ask you to engage again and simply answer the question of what does continuum of care mean to you? So if you can use your phones briefly or go to that website and answer that question, that would be great. Oh no. Consistency, support, housing, treatment, wraparound services, having a care plan, levels of care and wraparound services, maintaining stability, health, full spectrum, different levels of care is appropriate. Yeah. Offered at different levels, housing, medication, therapy, follow up and follow through. Oh, what a concept. Yes. Diagnosis, treatment until stable, care for the whole person, having a care plan. You got it. Thanks, you guys, for participating and answering this. Meeting the patient's needs wherever they are at. Absolutely. You got it. All right. So, in an ideal system, you want to have the right level of care provided in the moment of need to stop the progression of the illness and uplift the person onto a path of recovery. And as I've said before, we don't just want a pill and a bed, right? It needs to be more than that for our loved ones. But unfortunately, it isn't a reality yet, right? We have too many treatment barriers. And what we know is that, again, the average duration of untreated psychosis is 74 weeks, which is about a year and a half. And there's a data point that you can share with legislators that's impactful. Can you imagine if your mom had a stroke and you had to wait a year and a half to get her brain treated, right? That's a data point. It doesn't have to be amazing data points, but that's a very simple fact that you can share. And we know that outcomes are poor when psychosis goes untreated. More brain damage occurs, symptoms get harder to treat, but also people lose their footing in their life. They lose jobs, they lose the ability to get their degrees, they lose housing, they lose families, they lose relationships, and they get stuck in that churn when we don't have the full continuum. And you've heard me say churn a few times, and that's a term that was coined by a reporter that was doing the podcast series Lost Patients, which was based out of Seattle, Washington. If you haven't listened to that series, I highly recommend that you do. I think there's like 6 episodes. They do a masterful job of providing stories, but also doing an analysis from a reporter's point of view about why isn't the system working. So I would just highly recommend it. And when we talk about churn, it's talking about these repeated hospitalizations, homelessness, criminal legal system involvement, and suicide attempts. And they're calling it a churn because it isn't like the person's getting better while they're revolving through all these things. They are gradually getting worse and worse and worse, right? So when we talk about a continuum of care in the community on the outpatient treatment side of the system, things that we want to be advocating for are more first episode psychosis programs, which is really high level coordinated specialty care where they have 5 or 6 different professionals who are working with the loved one who's had their first psychosis and their family, and they stay with them through the first 2 years. This level of care is really helpful. They often help get the person a job before they wait for the person to become fully stable, because they know that keeping somebody engaged in daily life activities and with purpose helps them to gain that stability. I can't recommend getting programs like this going well enough. We finally got one where I live here in Johnson County. I've been advocating for it for about 12 years now. So, I also want you to hear from me. Sometimes it takes time, but you just have to persist. We need psychiatrists or other medical professionals who do psychiatric medication prescribing. We need therapists utilizing the evidence-based treatments like cognitive behavioral therapy for psychosis and others. We need to have assertive community treatment or ACT programs, AOT programs, assisted outpatient treatment, and we'll talk about that more in another presentation here. Peer support is really a key part because sometimes people hear things so much differently from somebody else going through the same experience. And then we do have to be holding insurance companies accountable for parity. Supposedly that's the law, but I think all of us on the ground know that's not the reality yet. In terms of the crisis and inpatient system, what we need are more mobile crisis teams integrated with 988 so that we can get health professionals responding to people in crisis, not law enforcement whenever that's possible. If it does still need to be law enforcement, we want to have it be crisis intervention team trained law enforcement that responds. We need crisis stabilization and diversion centers that don't care about insurance, that will take anybody. Prompt emergency evaluations in the community and any facility built for crisis care. We need acute care beds with adequate staffing and scope of practices. We need adequate state hospitals or other long-term inpatient beds. And we need accountability for responsible discharges and outcomes. We are seeing across the country more and more states putting in bills to hold hospitals accountable to do responsible discharge planning, to not just street people anymore. I have one in my legislature this year. Continuum of care for the lifespan. So long-term supports also need to be there, right? We need that transitional step-down care upon discharge from the hospital. And some examples can also be subacute care or partial day hospital programs. Sometimes those work for some of the people. We need crisis residential and respite programs. We need permanent supportive housing for some of the people who have the most severe illnesses and co-occurring disorders. And we need those to not just be private pay. We need some of them where Medicaid and Social Security help pay for that, right? And it's not just coming out of mom and dad's pocket. Intensive coordinated case management, so certified community behavioral health clinic models. We're hearing and seeing more the federal government push to get more states becoming CCBHC demonstration states and having certified community behavioral health centers around your state. They're being held to a higher level of care where they integrate physical care, substance use care, and mental health care all in one location. And they have to treat everybody from the day that they're born to the day that they die. And it doesn't matter if they have insurance or not. And they're held to account for outcomes. So they're monitoring people's A1Cs. They're monitoring how their cholesterol is doing. They're monitoring the person's overall health and reporting that back in order to receive their funding, right? That's a great, finally, build out of a system. That's probably what President Kennedy had in mind when he did the Mental Health Care Act back in 1963. Clubhouse International community centers are wonderful, and getting more of those to be expanded throughout the country. Those are lovely because it's a great place where people can go and start getting, some supported employment, get connection, more purpose and human connection, which we all know is a piece of healing. But we know there's a lot of gaps in the continuum, right? We don't have enough programs, providers, beds. And too few of the providers that are there will actually treat people with severe mental illnesses. Everybody that's out there and practicing, they're very much motivated to help people that are easier to treat, people with milder symptoms, right? And so we see a lot of cherry picking. They choose people with anxiety and depression because they're a lot easier to treat than somebody who's going through the revolving door with schizophrenia. And housing with support has not been considered a critical service within the continuum of care, which is contributing, as you know, to the streeting repeatedly of people that are untreated or undertreated. So what do I mean when I say cherry picking? People, when you go to the grocery store, you might pick for the best cherries in the thing to put into your own container to take home, right? And that's what providers do a lot. Hospitals are doing that now, right? Somebody presenting in psychosis to the hospital, they do some blood work on somebody in the ED. And if they find that there's a substance in the system, they just treat them. They don't even hold them and wait to try to get them into substance use treatment and mental health treatment. So we're seeing more and more of the providers kind of picking out the less desirable clients, unfortunately. So what happens with that is that pretty soon the criminal legal system is the only system that can't say no. And that's just wrong. Treating, what do I mean by that? It's when we see people that are basically just kind of pushed right back out that ED right onto the street. You see pictures on social media all the time of some patient, being walked out of the emergency department, literally in their hospital gown with their hindquarters showing. It's just unbelievable, but we have it happening all the time. And yes, it's against the federal EMTALA law, the mm, emergency medical something and treatment law, but basically they are not allowed to do that with federal law, but we know it's happening every day. And emergency rooms use a scale of needs system that pushes psychiatric needs to the bottom for triage. And that's part of the reason why you see psychiatric patients waiting so much longer in an ED than people presenting with any other medical condition. And we all know that there's also poor discharge planning and limited housing as well that are contributing to more and more people ending up on our streets. Barriers in the continuum, again, anosognosia comes up over and over again because even if we have some of these services and facilities available to people, too much of the time we rely on a person having to volunteer to engage with that treatment. And it is this huge priority of their civil rights to refuse treatment, much higher than their human rights for treatment and sanity and shelter. Misunderstandings and underfunding have limited the rollout of AOT or assisted outpatient treatment that could help these people. Insurance parity really hasn't been realized. And the other factor is that providers working in this very broken system experience a high level of burnout as well. The other thing that we see is a lot of providers have become people that have experienced what I call learned helplessness. And many of us might have heard the term learned helplessness talked about for our loved ones. They say, we don't want to keep your son or your daughter in our hospital or facility for too long because they'll learn to become helpless. They'll learn to have a patient mindset, right? Well, I began recognizing some time ago that providers have their own form of learned helplessness. They're the ones that throw up their hands and they say, we're so sorry, there's nothing we can do. We know we need to have a higher level of care for your son, but it doesn't exist. So we're going to send him back to your house, right? Over and over again. They start to see that they have to just accept that their plans are completely irresponsible, and they put it off to saying the law won't let me do this. Right. And what I'm here to tell you is that we have to push for what I call the starfish approach. You might not be able to save them all, but if every provider worked hard to do better collaboration with the other providers in the system and in their communities and create a plan of care that could help the person in front of them instead of throwing their hands up and saying there's nothing we can do, we really can help people one person at a time with intensive case management and better coordination between the different types of care facilities that we have. So every advocacy talk I do to provider groups, this is